So with these 9 success factors in mind, let's take a look at how the clinical microsystem might be represented in the context of providing care to a particular patient. This is a diagram that comes from Dr. Dan Duffy, the former Executive Vice President at the American Board of Internal Medicine and currently Dean of the University of Oklahoma Medical School in Tulsa. As you can see, the thing that we're most familiar with as physicians and care providers starts in that middle row there, where you have a patient who comes to the healthcare clinic, hospital, or some other setting, hopefully can get access to practice, undergoes a diagnostic workup, and then has a treatment plan generated, and hopefully the healthcare system provides the self-care support to activate the patient to meet their needs. This is something we're all very familiar with as clinicians. This is something we do day in and day out as physicians and other healthcare workers. But underlying that care process are a number of very important activities that make it possible, or hopefully make it of high quality and make sure that it's safe. If you look at the top, as we mentioned earlier, one of the success factors is measurement and improvement processes. This is a critical aspect. And one of the competencies now recognized as needed by all physicians is practice-based learning and improvement. Down below, we see a number of important systems activities that are essential to supporting that care process highlighted above. First is, again, teamwork and care management. Teams have to work well and be interdependent, as we noted earlier on the success characteristics. You need good clinical information management that helps to integrate all of the patient's care and make sure the care is coordinated and safe. And then finally, we know this care process of seeing patients generates all kinds of tests, consults, referrals, and other therapies that have to be well coordinated. And it's only through linking it with clinical information management systems and good teamwork can we ensure that that information gets back to both to the care team and to the patient to ensure their needs are being met. And so an effective clinical microsystem integrates all of these activities seamlessly and effectively. So with this kind of framework in mind about the important elements of clinical microsystem, let's take a look at another diagram that again comes from Eugene Nelson and Paula Talden and colleagues at Dartmouth. This comes from a textbook called Quality by Design, and I would strongly recommend it to all of you. But I want to walk you through this because I think this provides a very nice illustration of all the different microsystems that a trainee is likely to encounter, particularly in the field of internal medicine as an example. If you'll notice up top, we have a patient with a particular need. And in this case, that patient might have a cardiovascular problem. As you can see, the first microsystem that they encounter would be the emergency department. There, they need to be evaluated quickly. They may need to go to the catheterization lab if it turns out that they're having acute myocardial infarction. From there, assuming things go well within the cath lab, they are transferred to the critical care unit. And then finally, if they recover successfully from that acute myocardial infarction, they might be transferred onto a ward to finish their recovery. You'll notice here that there are 4 distinct microsystems, among others, that come into play in the care of this particular patient with a heart problem. You'll notice that the diagram highlights that each of those microsystems is responsible for delivering a high level of quality as part of the care received in that microsystem. We also have trainees in each of these microsystems. In the emergency department, you will have residents that need to evaluate the patient quickly and activate the other clinical care team from the cardiology service to get the patient up to the cath lab quickly. As we know, for example, in patients with acute myocardial infarction, that opening that blocked artery within 90 minutes or less represents not only high quality care, but helps the patient's recovery, enhances survival, and also enhances their functional status and recovery. Once they have received the interventional care in the catheterization lab, they're transferred to the CCU, where once again in a training institution, they'll encounter both residents and fellows. Those residents and fellows are often responsible for managing the day-to-day care of that patient. And then finally, the patient, as they're transferred out onto a ward, will encounter yet another set of trainees who will be responsible in making sure that they are beginning their recovery, to plan for that rehabilitation that's necessary after an acute myocardial event, and also to make sure that the patient is transferred appropriately to their outpatient physicians to continue their recovery and to address any other ongoing issues. As you can see, there are a number of microsystems that come into play in this educational process. So it's both a microsystem for the clinical care of the patient, but these microsystems have substantial impact on the trainees that are working within them. How they relate across those microsystems also relates to how they relate across these microsystems also is directly correlated with how they relate with each other. And so they have to learn to handle these transitions or handoffs very effectively. That's a systems issue. And so these microsystems are very deeply embedded in the educational process. They're not distinct. I just want to highlight one other thing about this diagram. You will notice that it is an inverted pyramid, which is a little bit counter to our usual way of thinking about organizations. What Paul and Eugene are pointing out here is that the senior leadership of the academic health center and the mesosystems, such as the other departments, pharmacy, discharge planning, the quality department, are all there to support the frontline units. The frontline units are the microsystems where our trainees spend most of their time. And so the institution, which spends a lot of time thinking about how they support these clinical microsystems, also needs to think about how they support these educational microsystems at the same time, because they're tightly integrated. So with that in mind, as we know these trainees have to work within multiple microsystems, we have to take a look, I think, seriously at our current training architecture, because this is a systems issue. You'll notice that within medical school, and particularly within a particular residency program, in this case I'm giving you an internal medicine example, trainees go through multiple rotations designed to help them acquire the knowledge, skills, and attitudes they need to enter unsupervised practice. This certainly makes sense to give them this breadth of exposure. But as you think about the success characteristics of a microsystem, and as we just took a look at how important it is to integrate those microsystems in the clinical care, we should probably take stock of the same sorts of concepts for our educational rotations as we move trainees from microsystem to microsystem on a fairly regular basis. And then within those rotational transitions where they encounter different microsystems, we know that each day they undergo a series of daily transitions that require a number of handoffs. So what I'd like you to do at this time is a kind of thought exercise. I would like you to choose a primary microsystem where your students, residents, or fellows spend a substantial portion of their time learning and caring for patients, and reflect for a moment on how well this microsystem meets the 9 success characteristics just listed. One of the things that we know is that in order to fully achieve competence within their discipline, they have to work in functional microsystems. And so as you think through those 9 success characteristics, where do you think your microsystems would rank on those 9 characteristics? Now that you've had a chance to reflect a little bit about how well you think your microsystems are performing from a clinical perspective, let's now change gears and think about specific systems in graduate medical education. And I want to start by talking about the important competencies of practice-based learning and improvement and systems-based practice. As you know, these are 2 of the 6 general competencies that have been promulgated and endorsed by the Accreditation Council for Graduate Medical Education and the American Board of Medical Specialties. This is our competency framework in the United States. And these are 2 of the newer competencies that tend to give faculty some pause and difficulty in understanding exactly what they're about. But I want to assure you that they're pretty straightforward, and they're also incredibly important in what we do. And in fact, this is the area that's probably where we need to spend a fair amount of time redesigning our educational systems in order to ensure our trainees can acquire these newer competencies. Let's start with practice-based learning and improvement. Greg Ogrank and colleagues wrote a very nice article back in 2003 and published in Academic Medicine that listed what they considered competence, in other words, good enough, to graduate from a training program in each of these two competencies.